Okay, we're going to do a little talk about protecting ourselves. We're going to talk about violence in the emergency room. So we did a little evaluation of our violence in our ER. In the past week, I can tell you we've had somebody that has been punched in the stomach. We had a nurse that had her shirt ripped off, almost, to where she had to run out of the ER. And we had one that was dead. So we're just looking at different ways that we can prevent some of this and de-escalate our patients. The thing is that we don't do it probably early enough, because we have that patient that's steaming and standing around waiting. The longer the wait, the more they get aggressive. And we need a standard of care, that getting their clothes out, taking their belongings, put them in scrubs. The cell phone's a problem sometimes, because they call people and then they get mad, or they call 911 from our rooms. So we took a look at 6 studies. Our big question was, are the emergency department staff who have de-escalating training compared to those without training at a decreased risk for workplace violence? So of course, through our 6 studies, most of it was different types of training. There's MANT training. I think the first initial training of that is almost a week long, and then like your renewal can be 4 to 8 hours, and that's every, I think, 4 years. CPI
St.
training.
Francis has CPI. They are actually implementing right now, and all staff has to go through, but they're offering it through various classes throughout the year. So they're a one day 8-hour training program, and then I don't know about follow-ups because we're just now.
All of this is kind of expensive. That's most of our limitations to the standard of care. Through our 6 studies, we did have, the strength is from a level 1 to a level 4. We have 2 studies that were a level 1, and we have 1 study that was, I think, a level 2, and I think we had 1 level 3,
And then
2 level 4s, and 1 level 5 study. But throughout the studies, most of them said pretty much the same thing. Standardized assessment of psych patients in conjunction with de-escalating training reduces the incidence of workplace violence in the ER, mostly, or psych settings, I would say. More, you might see that though in the ICU, of course. You probably see some of those patients. And of course, intoxication is the big risk factor. Some of the practice changes that we want are statistical analysis of pre and post implementation, like surveys, do some surveys prior to training and prior to just more standard of care, everybody doing the same thing. And audits, you have to audit. And then self-assessment, staff involvement, tracking the incident reports and the sensory reports are a big thing to find out what, number 1, your baseline is, and number 2, after the training, where you're at. And then a review of assessments. We made a checklist, and we're trying to improve our checklists, especially for suicidal people, about whether they have guns or what increases their mood and behavior. But a nice checklist in the computer, which we do have one already, but we need to tweak it just a little bit for our own. Do they have scrubs on? Do they not have scrubs on? Was police involved? Is there a petition for admission? That type of thing. A certificate from the doctors.
Do you want me to do the limitations?
Yeah.
Some of the limitations for the implementation of the de-escalation training would be cost. These programs are very expensive to implement. Taking the time off from on the floor and putting the staff through the programs is very expensive. And then you look at the number of staff that have to be trained. Essentially every ED nurse would have to be trained, and then you have to look at the other ancillary resources that you would have to worry about: security, the techs, even the physicians need to be aware of the training and the techniques that